Okay, well, welcome everyone, and I hope your week has gone well. Today we're going to be having our learning webinar and talking about metrics. A couple of metrics we're focusing on today are listed here. Avoidable emergency department visits per 1,000 patients and plan all-cause readmissions. So these words get confusing and jumbled up, and many of you might not be familiar at all. Others of you are much more familiar than I am, but we're going to talk about those today and see how that relates to the work that we're doing. So an overview for what we have planned for you today um, is I'll start out with just giving a real general informational topic explanation of the metrics. And then we'll move into having Rachel Inman present on how those metrics are things that they're doing to improve them and the facility that she works in. And then we're going to go on and have a discussion with some of our mobile integrated health attendees today and find out how it relates to the work that they're doing. And I just wanted to remind that our next shared learning webinar next month is not on the third Thursday because that's a holiday, but will be on the 26th. So it should be in your calendars that way, but just a reminder. Go ahead and get started. So why this topic? I really wanted us to kind of, it's always a path towards, well, kind of getting us all on the same page. But we want to understand these healthcare metrics. They're frequently referenced by payers and healthcare organizations. But those of us who are attending that might be in the community and not as familiar are also helping to improve the metrics. And I just wanted you to understand them and know how they're being looked at by others in our community. The goal is to understand how the work we do in primary care and mobile integrated healthcare settings influence these metrics and contribute to improved outcomes across the care continuum. So the first one we'll talk about is avoidable emergency department visits per 1,000 patients. So this one's probably most everyone is familiar with this concept and it makes sense. So the measure it measures emergency department use for conditions treatable or preventable in primary care or urgent care. It focuses on visits that don't require emergency department level care. And it highlights the system gaps, like it'll demonstrate the limited access to care. So a person who really would like to go and see their primary care provider, but it's just not available, so they need help and they go to emergency department. So that by looking at this metric, you can see that that's occurring and it goes up if, of course, if there's limited access to primary care. And then poor chronic disease management. So people who have diabetes, congestive heart failure, who are just not managed as well. This will also reflect in this metric. And then a lack of care coordination. So, near and dear to the hearts of all of you who are working on primary care with me and on the mobile integrated health. I know you're trying desperately to work together and have good care coordination, but for many reasons, it's not always what we're able to achieve for our patients, people in the community. So how is it calculated? So this is calculated by the number of avoidable emergency department visits over the total number of patients and then times 1,000. So if for this whatever population that you're looking at, if there's 300 avoidable visits and the population total is 10,000, then you have 30 visits per 1,000 patients. And what counts as avoidable? So emergent conditions that are preventable through appropriate preventive or chronic care management, non-emergent or semi-urgent cases, and diagnosis, just to make it make more sense, and is things like sore throat, urinary tract infection, ear infections, mild asthma, skin conditions. There are complex algorithms that are in place for, especially at health plans, that count this metric. And so, and it includes diagnosis codes and other things that I'm not familiar with, but it's something that's familiar across many organizations and is a commonly referred to metric. Why does it matter? We talked a little bit about that at the beginning, but it reflects primary care access and care coordination, so a quality indicator, and cost containment. Emergency department care is much more expensive than outpatient care. And oops, population health insight. So high rates signal opportunities for improvement, care coordination in the community. So how it's used, we see that in performance tracking and value-based care contracts. We see grant justification. So could be a way to show mobile integrated healthcare's impact on a certain patient population, and care management evaluation, and also for program and policy and program development for underserved populations. So I'm going to, before I move on to the next metric, is there any specific questions that anyone has about that basic information that I just covered about avoidable emergency department visits? Feel free to unmute and ask.
This is Kim.
Hi, Kim.
Hi. I don't have any questions about it. I've been working with this for like 25 years, but sometimes the avoidable that they count and is counted, as in my mind, against you is for something that it was not avoidable at the beginning, because one of the highest or one of the main things that always comes up when we go, what was an avoidable visit? It will be like unspecified chest pain. But until the person goes into the ER and has all the testing done, that you don't know that it's unspecified, and you certainly don't want someone to have a heart attack because you went, oh, it's probably nothing. The ER will just count you against me. So there's some plus and minus there, and things that are not quite so easy as some of this seems, just to make sure we're all on the same page.
Thank you, Kim. I really appreciate you mentioning that. And I'm so thankful to have Kim on today, as always. But she is a participant as a member of the performance measures coordinating committee with the healthcare authority in Washington State. So she works with these and many other measures quite a bit. And so I appreciate you weighing in on helping us understand that a little bit more, Kim. And there might be more opportunity for Kim to provide direction as we have other questions that might come up. Okay, so I'll go on and talk about.
Laurel, I have a question on that.
Yeah, go ahead.
Like in our community, we have the emergency department and we have the clinic. When the clinic's closed, there's nothing in between.
Exactly.
Does that show, because it would have been avoidable if there was another option kind of thing, and that would show as as an avoidable kind of metric.
It does. And so it's especially in rural communities, with that metric is going to show, there's limited primary care available, and you're doing the best you can with the providers are available. So the things that it reflects are not always something that are actionable. But it's a reflection to demonstrate exactly what's going on in that community. But yeah, lots of nuances. And Marianne, thank you for bringing that up, because it's absolutely true. And we'll see a difference, in our more rural communities on this particular indicator. Perfect. I forget where I was. I was going to talk about plan all cause readmission. So, PCR is sometimes the short way of saying that. So it tracks patients that are readmitted to a hospital within 30 days of discharge. It focuses on unplanned readmissions for patients 18 and up, and it's used to assess care, quality, coordination, and follow-up. The calculation is the number of unplanned readmissions within 30 days of hospitalization. So you're in the hospital, you go back home, and then you're back in the hospital again within 30 days. And that number is over the eligible discharges times 100. So the example is 50 unplanned readmissions for 1,000 discharges. So there's a 5% readmission rate. What counts as a readmission? An unplanned acute admission for any diagnosis within 30 days, not elective or scheduled. And an acute discharge can be from any type of facility, including behavioral health facilities. Examples are a congestive heart failure patient readmitted for shortness of breath, or readmitted for a broken hip from a fall. And what's excluded? So planned readmissions. So if it's a planned follow-up procedure, or like an individual with chemotherapy, they need inpatient chemotherapy, so they'll be back as planned. And patients who are currently receiving hospice or use hospice services anytime during the measurement year, who have passed during the hospital stay and who are directly transferred to another facility. The count that is from the discharge date from the second facility only. So why does it matter? So it highlights the problems with patient care, discharge, and follow-up. It's a cost reduction. Readmissions are expensive and often preventable. And it's a value-based care metric that affects reimbursement and penalties. So some applications are, hospitals that are working to improve discharge planning and transitional care. And I know lots of you are working on that. For payers, they can evaluate provider performance using this metric. And care teams target high-risk patients that have been identified that fall within a certain range above what it has been in the past. So you can focus on individuals, and then programs. So to demonstrate the impact of case management, home-based care. I'm thankful that Rachel actually shared a couple of links that are really helpful. One's the Washington State Common Measure Set, and the other one is a HEDIS guide by John Hopkins. So I'm going to stop sharing that and go over and let you see what is on those sites just really quickly. So this is the one that Kim is familiar with. The first one is it shows the Washington State Common Measure Set. And here it explains initially what it is. It's being used to track our ability to measure progress towards achieving healthier outcomes for all residents in Washington. And then I think it'll show up here. When you look at it, and I know you can't read it, but you can see at least the number. There's 62 here. And there's an explanation here of what they are. So I can send these slides out, and then also the slides from today's presentation will be available on our Greater Health Now website. So the other resource that I thank Rachel for providing was this. It's a really nice resource done by John Hopkins explaining the HEDIS measurements. And so really nice summary of them. So like, for instance, we were looking at plan all cause readmission. So close your eyes while I scroll. Try to get to. Oops, too far. So it's talking about different product lines with payers that use this measurement and gives you the measurable population, the definition, lots of specifics about this specific measure, the exclusions. So really nice resource for us, and it's available here with the link. So with that, I am going to stop sharing and pass it over to Rachel, who's a population health manager at Cadlick Regional Medical Center, and has been a wonderful person to work with me for several years as I've been working with Greater Health Now and practice transformation. She's very dedicated and works very hard. She's a medical assistant, certified in her background, but has done so much over the past years for serving the patients in Benton and Franklin counties. So I will turn it over to you, Rachel, and let you share your screen and the information that you've prepared for us today.
Great. Hi, my name is Rachel Inman, Population Health Manager here at Cadlick. I've been in this role for about 4 years, and I have to say, can everybody see my screen okay?
Yes.
Okay. I have to say such a big thanks to Laurel and the Greater Health Now team for all of the practice transformation activities and tools that they provide that really I've learned so much from, and have been able to implement a lot of the techniques I'm going to talk about today for making an impact in these measures. So thank you, Laurel.
You're welcome. And it goes both ways. I'm learning from you these days. Thanks so much, Rachel.
I wanted to do a quick review. Laurel called out why these matter and kind of what they show performance on. So for avoidable ED, really reflecting that primary care access and care coordination. We care because, ED care is more expensive than outpatient care, and high rates of avoidable ED use really signal those opportunities for improvement. For plan all-cause readmissions, it's used to assess care quality, coordination and follow-up, discharge planning and transitional care. You can target high-risk patients for intervention and demonstrate the impact of case management and home-based care. We'll jump into avoidable ED and how to get upstream for that. I agree, it can be hard. The way the measures are defined sometimes, I'm like, how can I get on the HEDIS board so I can help write some of these measures? Avoidable ED use can be a tough one. But I think the most important thing is to understand your population. You want to make sure that you're getting those ED visit notifications. I know we've had Point Click Care come on and talk about their services. That's a great way to identify those visits. And then just looking at the trends in your data. What are the reasons that the patients are using the ED? See if you can find some of those biggest diagnoses or things that are going on, and be proactive to address those factors leading to the visits, and use PDSA, monitor the impact of your changes. When you're just starting out, I know one of the things as we go through practice transformation is sometimes these are big populations, these are big projects. It's hard to do everything at once. So, you can start small. If you choose a smaller subset of population, maybe you want to do all of your Medicare patients, or really I would recommend starting with patients that are already high ED utilizers. It's usually a smaller population with a potential for a big impact. And you can look at those risk factors for potential high ED use. I think that's risk stratification, right, Laurel?
Yes.
So some of those factors might be uncontrolled chronic or behavioral health conditions, can be more complex, social determinants of health issues, polypharmacy, things like that, you'll notice trends in your data. Some of the common reasons for AED visits that I've found, when people are going into the ED for non-emergent reasons, it's usually an access to care issue. They don't have a PCP, or they don't have a good relationship with their PCP. They don't have that after hours access, poor availability in the appointments. I know most of our providers are scheduled quite a ways out. It can be tough to get in. You want to make sure that you can hold back some appointments on schedules for urgent visits and things like that. And then uninsured patients. This can be especially tough in patients that are not insurable. We try to connect folks for resources to sign up for insurance, but there are some barriers there as well. Those emergent AED visits that are potentially preventable usually highlights the chronic care management gaps or lack of care coordination between providers. I'm sorry, I did not make pretty slides today. I'm going to do a lot of talking. I really just listed out a lot of the techniques that we're using and techniques that we would like to start using as well. But just really addressing each of those areas. So for folks with no PCP or lack of PCP relationship, we really engage our community health workers. We engage community health workers from the hub, but they have a campaign. So whenever our community health workers are out at events or out in the community, they are talking to people about whether or not they have a PCP. They created a great brochure that's pretty unbranded. The Right Care for You, Right Side of Care for You brochure, I believe it's called. And it's really our goal is to get folks established with a PCP, whether it's a Cadlick PCP or another location. The brochure talks about, veterans health care for folks on TRICARE. It talks about the benefits of our federally qualified health center for folks with Medicaid, and it lists our clinics as well. So they help people get established. We partner with mobile health units, so we're able to tell folks in the community that don't have a PCP about the mobile health unit. That's an amazing way to make sure that people are getting care that wouldn't otherwise have access. And we are opening, my newest project is opening a bridge care clinic that will hopefully impact both of these measures. Appointment availability is the same for new patient availability. Sometimes you call to establish with a provider and you don't have a new patient appointment available for 6 to 8 months. If you have a chronic condition that needs to be managed, you need to be seeing someone in the meantime. So we are opening up a clinic to try to help bridge care for folks that are waiting to establish with a primary care provider here at Cadlick but need some care in the meantime. I hope to give you guys updates on that by the end of the year.
And then also on Rachel, excuse me, on that one, was that also for transitions of care as far as people needing appointments after they've had a hospitalization?
Yes. I listed on my my TCR slide as well, my transition.
Oh, okay.
Slide as well. So I love that. I like whenever we can do a 2-for-1.
Yes. Yeah. Okay. Good.
Somebody mentioned after hours access, especially when you're in, a rural community. It can be really tough if there's just not other options in town. You can think about extended hours, how you provide on-call access. But in those situations, I really lean on patient education. There's 2 things that we do here at Cadlick. We have a Where to Go When You Need Care brochure. It's really nice. It really lists out some common reasons that folks go to the ED that they don't need to go to the ED. You can wait until you can see your PCP or talk to your provider the next day. So it really calls out, the different options that are available in our area. And then trying to educate new patients on the fact that their insurance card usually has a triage RN line number on the back. You can call that number anytime, day or night. I've used it multiple times both when I did not think that I needed to take my child to the ED, but the nurse said, you do. And when I thought I did need to go, and the nurse said, you can wait until tomorrow. So I've used those services. I think they're great. I love to point them out to patients. This is a way that you can find out where you need to go if you have a potentially emergent situation when we're not available. Appointment availability, tough problem that I know everyone is facing. We've got such a shortage of primary care providers across the nation. One of the things we lean heavily on is our extended care teams for follow-ups. If patients can come in and follow up with someone other than their primary care provider, that leaves more access for other visits to be seen. So we've got pharmacy, they might do follow-ups when we're still working on adjusting a hypertension medication. We have behavioral health integrated in the clinic so patients can come in and follow up on behavioral health issues. We have care management teams that might reach out and help with behavioral interventions or lifestyle, different self-management techniques for patients in between visits. Really excited that we're going to start attempting some nurse flex visits. I think this is commonly referred to sometimes as flip visits or flex visits, but this is when the patient comes in and sees the RN, but RN has the ability to pull in a provider if the problems or the situations go out of their scope or they don't have a protocol in place. So they might see a patient after a medication was changed, and if patient's still not within targeted range, they can grab the provider to come in and make that recommendation to increase the medication. Or they might have a written protocol where they can increase the medication following those guidelines. So I'm really excited to get those going. We're going to use them for annual wellness visits as well. Those really help open up access. And then our mobile health unit, I can't tell you how much we appreciate and rely on the services provided there when patients cannot get in or just don't have that access to care. Uninsured patients, I mentioned earlier, that's a tough one. We engage our community health workers to help people sign up for insurance. They have good relationships with folks at DHS. We have the mobile health unit that does sliding fee scale appointments. We try to connect people with the financial assistance available through Providence if they need to come in and see someone here and just don't have insurance. This can be a tough one depending on the population that you have. We have a high population of people that are not insurable here, don't qualify for those benefits. And so finding care for them can be difficult. And I just go back to the mobile health unit that we are so thankful for. I'm doing a lot of talking. I'll pause here if anyone has any questions, but feel free to jump in at any time. Making an impact in those more complex patients is a little tougher. Those folks that might need more care management or have social determinants of health barriers, there are still things that we can do to try to get ahead of this. We want to make sure we're following up after ED visits. So we're getting those notifications when folks are discharged from the ED. We're reaching out and following up. Did you understand your instructions? Were you able to get any medications? Are you having any issues? We will schedule an appointment with the provider if needed. Otherwise, give them, a number where they can follow up if they do have any further concerns. Implementing chronic care management to work with patients with uncontrolled chronic conditions. Care coordination, reaching out to folks with chronic conditions, making sure they get their referrals scheduled, making sure that they're keeping their follow-up appointments. If they're due for labs or testing, we're making sure that they know when they're getting out, outreach to people to make sure they get those things. We've got, again, engaging our community health workers to help, especially if folks have social determinants of health needs. They can connect them to resources. Greater Health Now has the hub. You can refer to their community health workers, utilizing social workers in the clinics as well to help with a little more complex social determinants of health needs. The ability for the clinics and the caregivers at the point of care to make referrals to community resources, to give information on different community resources to help these patients is really important. We just went live with some integrated resources in we use Epic as our EHR. I haven't gotten a chance to touch those yet, but in the background, our community health workers keep a long list of resources available in the area that they can refer people to and share with caregivers in the clinics. Another little risk stratification shout out there, just really watching for those trends and the folks that are high ED utilizers. What are you seeing, and how can you reach, make sure that you can identify and reach out to those people ahead of time. And patient education, self-management, behavioral interventions. I think that's part of your chronic care management.
I just want to comment, Rachel, that it's so exciting to see, like, when we started working together several years ago and our first waiver work, and with Molly Calhoun, there's like a lot of these things just weren't in place, but it is a lot of growth in really relatively a few years. And the focus is so wonderful. I mean, to just be able to have that integrated behavioral health, you just talked about having a social worker embedded into a clinic to help with some of the more complex social needs. Applying that risk stratification is no easy thing, of trying to find the patients most at risk in need of care management. So many things. I just have to comment. I'm just so excited for the work that's been done, and it doesn't go without a lot of sweat and tears, really, to try to get there. So thank you for sharing this stuff so far, and please continue on.
It is a lot of work. I thought about you a lot, Laurel, as I was making these slides. I remember when you helped me recognize that we were doing risk stratification. That was just too big of a fancy word for me.
Yes.
And so even just being able to bring forward the things that we're already doing, because I think it makes such a much bigger impact when you're doing things on purpose. There might be things that we're already doing if we don't even realize it. Once you realize that and you're doing it on purpose, and you can talk about the why and educate your caregivers on that, it's such a change that really helps with the culture change that some of this work brings as well.
Mm-hmm, mm-hmm.
I was going to move on to plan all cause readmissions. This is when I'm really just jumping into, I've focused so much on the outpatient setting. We're really just jumping in here. So getting upstream with this can be a little tougher, really just depending on the type of data you have available, and the area that you're in, the healthcare entity you work for, kind of what's around you. But I do think that there are ways to address this in any healthcare setting. Kind of the same things as avoidable ED use. You want to understand your population. So having a way to track readmissions, or even better, making sure that you have a daily census of what patients of yours are currently admitted inpatient, and identifying those common readmission reasons, addressing the factors and impacting, monitoring the impact of your changes. Some of the common reasons for readmissions, and this can vary very widely. I didn't jump into common diagnostic reasons for readmissions. Sepsis, if folks are like us, sepsis is our biggest readmission risk there. But again, inadequate discharge planning or poor patient education on discharge, no follow-up with the PCP after discharge, patient receives referrals to specialty or for DME, not getting those referrals, not scheduling those appointments, patient not understanding their new medication regimen or being unable to receive some of those medications. Sometimes they require prior authorizations. That's a lot of people working on one patient's chart. So who's doing the prior authorization? Who's taking this patient once they're discharged? It can be tough to coordinate. And then poor self-management or lack of support with care at home. I think often you have folks that say, I really want to go home. Oh yeah, I've got I've got my daughter that comes over every day. She's going to help me. And really they get home and daughter's not available and they don't have the ability to really care for themselves at home as much as they wanted to be there. We can impact this through improvements in discharge planning, just really looking at the processes. We're doing a lot of, a little lower on the list there is a readmissions review council. So this is something we've just started here. And while the lift in the beginning is quite heavy, I've done a lot of chart review in the last 2 weeks. We are reviewing all of our readmissions for the last 8 months so that we can try to identify trends, see where we can put improvements in place so that we can improve that discharge planning. Again, with the risk stratification, making sure you know those trends so that you know who's at higher risk and can outreach to them. Engaging with our skilled nursing facility partners and our home health partners. They take patients after acute discharge and they really have the ability to make an impact with the patients there in the readmission. So we have a monthly meeting with our skilled nursing facility partners where we just talk about any barriers they're facing, any ways that we can come together and help. So for example, they were having a lot of trouble with some of the medication orders that were coming from the hospital when patients discharged that were preventing the patient from coming in, or sometimes the patient wanting to discharge from the skilled nursing facility before they were ready because they wanted to get back to certain medication regimens that just weren't available in the SNFs. We were able to work that out together with them. We're able to partner with them and help offer BLS training to their caregivers. It's really a great relationship when they have the 30-day readmission measure too that they're looking at. So it's great when our measures overlap and we've got a common goal to work towards. And then again, I'm so very excited for this bridge care clinic that we're hoping to open in July, where we can see these transfer TCM visits, transitional care management visits at the bridge clinic for patients that can't get in with their PCP or do not have a PCP. And then I skipped one thing on my list because I've got a little bit more to say about it, and that's the transitions of care measures there's 4 measures there, and they really impact your performance on this readmission measure. So if you're part of value-based care contracts and you're involved, you receive reimbursement, and that way you've got quality measures that you're looking at. Especially if any of them are Medicare, I am sure that you are familiar with these measures and the transitions of care measures as well. But the transitions of care measures kind of organize all of those follow-up activities after a hospital discharge. And there's 4 different parts of those measures. There's notification of inpatient admission. So you want to make sure that you know when your patients are in the hospital so that you know when to follow up with them. You need also that receipt of discharge information. Very lucky that we have a lot of patients that come to the Catholic Hospital, and therefore it's already in our electronic health record. But again, point-click care and just building relationships with your local hospitals to make sure that you're getting discharge reports can help as well. Another part of this measure is patient engagement after inpatient discharge. So that's those follow-up cares. We have RN care managers that are following up with all of our Medicare patients after patient discharge, making sure that they get scheduled to see their provider within 14 days for a TCM billable visit, but the measure is actually within 30 days. And if they are unable to follow up with their provider, just really providing that care management support. And then medication reconciliation post-discharge, making sure that that's happening, that you're specifically talking to the patient. I talked about this a lot in the beginning because I said, we review the medications at every visit, and we do. I go through and, I would read every med that was listed in their chart and say, you still taking that? Yeah, okay, great. But I think when someone's discharged from the hospital and there was medication changes, being a little bit more specific, okay, you were previously taking this, but they stopped that during your hospital stay and we replaced it with this one. Have you been able to get it? Are you taking it as directed? And then anytime I'm talking about medication reconciliation, I can't help but put a plug in for giving a safe space for patients to tell you that they are not taking their medications as directed. I always go, yep, I take my meds. But really, there's definitely times where I'm probably only 60 or 70% compliant. It's important that when we ask these questions, we're letting, patients feel safe to tell us, you know what, I'm really having a hard time to remember that one I'm supposed to take every day after lunch.
Rachel, I want to have you,
Yeah.
I want us to pause here because you just hit these points here of your TRC measures really are, I mean, as far as mobile integrated health and the work that they're doing out in the community, these really cross over really well. And so there's a couple things I wanted to note for the mobile integrated health providers is like, it's hard to understand the language. I don't know, of this talk, even when we first started talking about practice transformation and all of the terms and everything that are referred to in clinics. But I wanted, like, part of the goal of this was to help them understand like what's important on these measures and why. And so they, like, on my ride-alongs with them, like medication reconciliation. Oh my gosh, Rachel, you should see how cool it is when they're just standing there in the home and there's piles of medications and bubble packs and all kinds of stuff all around. And, when you're talking about it, leaving a space for them to say what really is going on and where they really are confused, you can see the difference when you're standing in a clinic and getting ready to go to see your provider versus someone standing with you in your home and they have a measure of trust with you. They get so much information. And so it really has a potential to impact this measure. But I wanted to draw that out, and in a minute, we're going to get some sharing of cases with our mobile integrated healthcare attendees. But I wanted to ask, and maybe you have this on your 10th slide, and I'm jumping ahead of you again, which I'm sorry if I am. But when you talk about these measures, and so even overall of the two measures, so who asks you, like, how is it you're responsible, like, with these measures? It's not just something that you go, we'll pick this one out of the sky and be responsible. So how is it, like, important for getting payment? I really would like all of us to get a better grasp of that. Like, who's asking you and why, and what difference does it make, especially for contracts?
I wish, Laurel, that I was picking what measures we had in our contracts. I would pick all the ones we're already doing great at. Some of these measures are just hard. I do feel like I get to be the face of the person that's out talking about these measures, and sometimes I have to remind people, like, I am not drawing these out of a hat. I didn't write the definition.
Mhm.
That hypertension measure definition really kills me. But when we enter into these value-based contracts, it's really, the goal of value-based care is to help us achieve the quintuple aim I think we're at, but I really just go back to that higher quality of care with a lower cost. And so in these value-based contracts, they want us not just to keep the cost low. We could keep costs low by giving no care to patients. They want us to keep the cost low and show that we are still giving quality care. So in the contracting process, as part of an organization, I'm not at the table for that, but we negotiate these contracts with payers. I think the payers and generally have, what measures they're really keeping an eye on as well. And so those go into our contracts, and that's what we really look at is what was the cost of care and what was the quality. It's important to our payers as well because, often their star ratings or their performance is based on things that they can't really control. It's based on the care that we give, and then they're rated as a plan with what kind of care their members get. And when they have better ratings, they are eligible for different bonuses from CMS, which they then generally put back into their healthcare plans. And that's why you see like Medicare Advantage often offers low or no premiums. You'll see vision coverage and dental coverage sometimes on those Medicare Advantage plans. And that's because those payers are taking those bonuses and putting it back into the benefits for their patients. So I really think the VBC contracts, the alternative payments are really pushing us towards this practice transformation. You have to do something different in the way you're delivering care in order to be successful. And that's really the world that I live in most of the time, is working with our VBC contracts and our measures there. I did not put our mobile health unit on this slide, but I really should have. They are so great, especially on preventing readmissions. Just some examples I can think of are even just patients coming in for suture or staple remover. If you don't have a PCP, you're going to go back to the hospital for that type of thing. If you are having trouble understanding your discharge instructions, or you're having some complications after your discharge, to be able to go in and be seen at a mobile health unit is invaluable. And that really, my last slide was really just a big thank you. I think I said it at the beginning, though. Just learned so much through this. Appreciate you all.
Okay, I just love that presentation. I thought your slides were very pretty. That was great. And I really appreciate words instead of someone just saying the words on a slide, and you did that really well. So I know there's probably, I hope that people would want to weigh in. And one of the things that I would like to do is first give an opportunity for other primary care organizations to say anything else that you want to about that last point of like, well, why do we care about this measure? Because I really want us as a group to understand, okay, we have opportunities to to understand like who's asking the questions on these measure sets. Are they really important? And also to understand what the measures are. So anyone on primary care want to add anything to this conversation?
I know I learned not just from Laurel, but also from these meetings and the great work that we're all doing, the different things we're trying here to impact change.
Yeah, it's been really valuable. I learned from you all every meeting on things, so I really appreciate it. So I want to go ahead and move on to having, just kind of flipping over to having some people from our mobile integrated healthcare teams to share about a patient scenario. So we just got a great introduction from Rachel on like some of the things that really matter to help move those metrics forward. So are you guys doing anything out there in mobile integrated health that helps that you can think of? Because I would think you might be ready to mention them. And I don't know, we have Bobby on and we have,
Hey, Laurel.
yeah, and
Bobby.
Mary Ann still.
Yeah, for those that don't know who I am, my name is Bobby Marsh, community paramedic with City of Clarkston Fire Department. Going on the medications and just kind of echoing what was talked about. I run about 600 calls a year. Every patient that I visit with, I normally obtain like a baseline set of vitals. They have a lot of complex medical conditions. Some of these patients are taking 15 or more medications in a day. So to add another medication to that patient's list and expect them to remember it and take it on a schedule is kind of a big ask. And I think that's probably contributing to patients returning to the ER. I wouldn't necessarily call it non-compliance, but maybe non-adherence to treatment plans. So typically when I go in, I get a set of vitals. On this particular day with this patient, I was able to identify sepsis in the field. So this did end up in a transport with sepsis. It is a life threat, so that needs immediate treatment. This patient was transported to the ER. They were admitted for a few days. Upon release from the hospital, I made contact with the patient. She has no transportation. In-home care is hit or miss, so I'm probably the most consistent care that she provides in the home, or that I provide in the home. So I was able to pick up her antibiotics from the ER, and then I just performed frequent follow-up visits to ensure that she's taking those antibiotics and finishing them. And that's just a drop in the bucket for how many times this has happened out in the field. This is honestly kind of a regular occurrence.
Yeah, I thank you, Bobby. So Bobby's in Clarkston, and I had the pleasure of riding along with him recently and seeing some of the people that he gets to encounter and work with and help. And I wish you all could do it. I wish you could see what's going on in this setting. So there was another gentleman. I'm thinking of the guy who you're trying to catch our atrial fib. And you know how the multiple complex issues with this gentleman, and you know just that he was so happy to see Bobby and that he would come in, so that trust level, and then you know just to get that check, you know. So here's a guy who's going to be, I don't know, Bobby, if you want to talk about like how much he was in the hospital, and then how that's changed since you've been having visits with him.
Yeah, he used to be a high utilizer. At times, he still can be. Um, he's had issues where he's been transported for weakness, dizziness, frequent falls. It goes undiagnosed. He's kind of just released with general weakness and sent home. During one of these episodes that he was having maybe a couple months back, he called me rather than calling for an ambulance or calling his doctor. So I responded to his house, performed vitals. I decided to do a 4-lead on him and noted that he was in AFib at a pretty rapid rate. And he has no history of AFib. Really, it's just been undiagnosed. And then I came to that conclusion that I think he's having these bouts of AFib, and it's causing these days of weakness and dizziness, and it's been undiagnosed and untreated. So at that point, obviously, I have to have him go up for evaluation and treatment. But being able to catch that in the field and have proof of it on a 4-lead rhythm strip interpreted by a paramedic, and you know that information given to the ER, he's able to get treatment for that now. And I still see him regularly, more probably because he wants to visit, but I do occasionally check his vitals and things like that, and we don't see him nearly as often as we used to.
Yeah, and it's just like he's living a much healthier life than he was prior, just with these little help outs. I mean, even just seeing a smiling face. And I walked in as a nurse, and I'm like, Bobby, those meds. He had like a whole table full of meds, and you know, he he didn't want to do the pill boxes or anything. So, you know, just working with people where they're at, and you know, try and help them be, you know, the best that they can for their health and overall well-being. So it's just an honor to go out with you, Bobby, and with the mobile integrated health teams, and just get to see what they're doing. And in the clinics, I know you guys would just be so impressed to see the work that they're doing. And I, from being in the clinics, it's so hard to get to that level of understanding or being able to teach or help or you know connect. Hasn't happened in other settings. So I also wanted to give a chance. I think we still have, it looks like we lost a couple of our MIHs, but Marianne, you're still here. Thank you. Can you talk a little bit about someone or anyone that that you've been helping that might impact either of these two measures, the work that you're doing?
Absolutely. I could probably spend all day talking about it. So on things like medications, we do a lot of work with our patients. We go in, we'll pick up prescriptions. If somebody's not taking their medications, because we set up their med boxes according to what they want. If they're not taking something or not wanting to, we can sit there and have the discussion. Well, why not? Oh, it makes me pee all night long. Well, let's put that pee pill in the morning instead, or, I don't feel right, or, whatever it is, we can talk to them about it. And then if we need to, we'll immediately right then and there call their PCP or call the pharmacy, see if there's an alternative, or, if we can make a change or something like that, so that we can address their concerns right then and there, and not have to go, it's a question more than you get in the clinic of, oh, are you taking this? Well, sure, I'm taking it. But, we go into, hey, I can see you've taken this or you haven't. And why are you pulling this one out all the time? And what's going on? And, we're right there in the living situation, which, we can get a lot more people being on stuff. Or if they're choosing not to, they can very clearly see the impact. I have a lot of people who have over time don't want to take their Lasix or whatever. And it's like, hey, we can show that when you take your Lasix twice a day, your blood pressure comes down, you have more energy, now you're not taking it, you're only doing it once a day. Look, your blood pressure's coming up, you're getting crackles in your lungs, we can correlate those things with them, which you can't do in a doctor's office. And then at least then they're making educated choices. Truly educated, because they've seen in their own body how it changes and they trust what we're saying.
Yes. Yeah.
So,
I too, Marianne, could go on all day about, I love these stories, and there's just so many things, the mobility, people who have mobility issues, limited mobility, that you and Bobby and the other MIHs are doing to help bridge that gap, connecting to resources, just like, oh, here's this side rail, here's to help you from falling out of bed. It's just so much that
absolutely
is happening.
One of our very earliest patients actually went in for the same surgery 2 years in a row. So the year before we started our program, he had shoulder surgery. We were out there like 4 to 6 times a day for the first 3 or 4 days he got home, because he kept falling. And we kept getting him up. He may have gone back to the hospital at one point. I don't remember. It's been a while. But the following year, he had the same surgery on his other shoulder. And when we got called out, because he's being released from the hospital on a Friday,
And
we get called out Friday night.
Pomeroy.
Yes. And we get called out for a lift assist. And our program had just started. And I get called in going, hey, this is what's going on. I'm like, okay, sit down with the family, figure out where the, weak points are in the situation. Within an hour, he had a transfer chair, a bed rail, commode, handles over his regular toilet, and a shower bench. And you know what? We didn't get another call for a lift assist in the entire time.
That's amazing. It's amazing.
That's the difference, and he's a great case to show that in between. I have another patient right now that we got her and her husband a sit-to-stand device, and it's been great for her. She used it all day, but we were still picking them up at night. And I was sitting there having the conversation with her after one of the lift assists in the evening, going, what's going on? She's like, I love this thing. It's great, but he can't use it. By the end of the day, he's 2 weeks. So through the conversation, it was, well, at what point in the day is he getting too weak to do this? Well, it's after dinner. He has dinner about 5. He goes to bed about 7. The discussion became, it's like, well, maybe if you want to bed an hour earlier. Since we've had that discussion, we haven't been going out for those lift assists.
That's amazing.
And any of these lift assists can turn into a transport. Any of them.
Absolutely. And transport to the emergency department, which increases those avoidable EDs, and also potentially, an unplanned hospitalization. So both metrics. But I appreciate your sharing, and I wish we could go on, but it is noon, and I promise to be paying attention to everyone's time. And I know it's kind of the tip of the iceberg, but I wanted to bring us together on these metrics to just kind of see, okay, how can this be? How can we work together for communities that have it in place? So I know Stephanie was on, Marianne, so hopefully it helps to understand the metric, but and the goal overall, and then how can we
Laura,
work
I think
together?
Cindy's got a question.
Oh, Cindy, go for it.
Oh, I think it was a while ago. Sorry,
I'm
I forgot I
sorry.
even asked. No, you're okay. I was just gonna say I had the privilege also of going out with Bobby, and it's really a lifeline, and it's almost like doctor on call, you know, back in the old days where you could have someone come out to your house. And I don't know. I just think it's a really great program. I watched him work in our community, and I just honestly, Bobby, cannot brag enough about your connection in our community, the way you approach your clients and how supported they feel by you. I know it's a great program, but you're also just a really great fit for us. So thank you.
Thank you. I appreciate that.
It's good stuff. Thank you so much, everybody. I hope that we, came close, for our goals of, exploring two commonly used healthcare metrics, and they sound like a different language a little bit, frequently referenced by payers and healthcare organizations, and to understand the work that we're doing in primary care and mobile integrated health settings to influence the metrics and contribute to improved outcomes across the care continuum. So that was the point. I hope it was valuable for you. And our next time that we get together will be June 26th, and we're going to talk about screening for health-related social needs. So thank you, everybody, for attending, and I will let you go.
Thank you.